of the International Conference on Advances and Challenges in Maternal and Infant Nutrition, organized by the Nutrition Society of India, Chennai chapter. On behalf of the organizers, I extend a warm welcome, first and foremost, to Dr. Soumya Swaminathan, a renowned scientist from India with international distinction and repute, who is currently the Chief Scientist of the World Health Organization. It is our honor and privilege, ma'am, to have you give the special address on this occasion. Thank you for making the time and space to share your expertise and experience in this forum. I also extend our greetings and welcome to the other experts who will contribute to the proceedings shortly. A warm welcome to Dr. Praveen Kumar, Director and Professor of Pediatrics and Deputy Head and Coordinator of the National Center of Excellence for Severe and Acute Malnutrition Management at Lady Hardinge Medical College and the associated Kalavati Saran Children's Hospital, New Delhi. I also extend a warm welcome to Dr. Sharika Yunus, Head, Nutrition and School Feeding Unit of the World Food Programme. A hearty welcome to Tirumati V. Amudavalli, IAS, Director and Mission Director, Integrated Child Development Services, Government of Tamil Nadu. We are happy to welcome Dr. A. Lakshmaya, Scientist and Head, Division of Public Health Nutrition, ICMR, National Institute of Nutrition, who is currently the National Secretary of the Nutrition Society of India. I also welcome all the participants, including the students, research scholars, faculty, media persons, and my colleagues and friends to the conference deliberations. Thank you.
Lakshmi, please unmute.
Thank you so much, ma'am, for the wonderful welcome address. The special address for today is to be delivered by a renowned scientist, Dr. Soumya Swaminathan. I would now like to welcome Dr. Rama to introduce to all of us Dr. Soumya.
Thank you. Can you hear me?
Yes, ma'am.
Okay, thank you so much. And I'm personally delighted and as well as honored to be able to say a few words about Dr. Soumya Swaminathan. I don't think I should use the term introduce her because I think she's already very well known as the Chief Scientist for the World Health Organization. Nevertheless, I would like to share with you facets of her professional career and her achievements. She, by professional training, she is a pediatrician and a clinical scientist, and her domain expertise is in the area of tuberculosis and HIV. She did her MBBS from the Armed Forces Medical College, Pune, and later on went on to do her MD in pediatrics from the All India Institute of Medical Sciences. This was followed by a postdoctoral fellowship in neonatology and pediatric pulmonology at the Keck School of Medicine in Los Angeles, California. She also did another fellowship from the Department of Pediatric Respiratory Diseases from the University of Leicester, UK. She was very clear that she wanted to use her services and skill and knowledge for her own country. So in 1992, she came back to India and she joined the National Tuberculosis Institute at Chepauk, which she served for about 18 years. She researched mainly on TB, and she was one of the pioneers in the use of the markers, molecular diagnostics for TB surveillance, and also to deliver TB treatment to the marginalized sections. She was also part of the Zero TB City project in Chennai, and she has worked with a lot of local government institutions, as well as grassroots institutions, NGOs, as well as the government. Her stint with the World Health Organization started in 2009 when she became the coordinator of the WHO Special Program for Research and Training in Tropical Diseases in Geneva. In 2013, she became the director of the National Institute of Tuberculosis, which she had served for nearly 18 years. And in 2015, she moved on to become the Director General of the Indian Council of Medical Research and is the second woman to lead the institution, which oversaw about 30 other research institutions. Her main focus during this period was to bring science and evidence-based research into policy making and building the research capacity of the medical schools in the country. In October 2017, she was appointed as the Deputy Director of the World Health Organization, being the first and the only woman and the only Indian to hold the position. Her dedication and result-based performance elevated her to the position of Chief Scientist in 2019 with the WHO. Her work mainly included health-related research and translating it into clear guidelines for all the nations. In 2021, she was also appointed to the Pandemic Preparedness Partnership, PPP, an expert group to advise the presidency held by the government of PM Boris Johnson. I think all of us here were familiar during the pandemic time with the periodic appearances on the local media and TV, whenever she was called in to give her expert advice. And she has several awards to her credit from leading Indian institutions. In 2008, she had the Shanika Oration Award for the Indian Council of Medical Research from the Health and Family Welfare Minister. In 2011, she got the Lifetime Achievement Award from the Association of Applied Microbiologists. In 2012, she was honored with the National Academy of Sciences India, and in 2013 from the Indian Academy of Science, Bangalore. In 2016, she received the Nipper AstraZeneca Award, and in 2020, she was honored by the Tamil Nadu government for the services that she rendered in combating the COVID-19 pandemic in Tamil Nadu. And personally and professionally, I have interacted with her several times, and I've always found her to be a very down-to-earth person with a ready smile, with a keen interest in the professional environment around her. And I think the combination of the professional zeal as well as for serving the community comes from a background that was rooted in this, since both of her parents, who were very well known, her father, Professor M.S. Swaminathan, was a scientist par excellence. And I think the scientific zeal and training she had from him probably. And Mrs. Meena Swaminathan, her mother, was not only an early childhood expert, but was a theatre activist who used theatre as a tool for communicating several messages, including gender and so on. So I think this combination of science as well as serving the community has served her in good stead. She has had her early training from her parents even before her professional career began. And this is why I think she used this the combination of and whatever she had the background and upbringing in serving the community. Because I remember that when she was involved with the TB program in Tamil Nadu, she not only had she heading the scientific division, but she also used to visit the homes of many of the participants, in the slums and so on. So I have personally found her to be a very warm person, very down to earth, and you can reach out to her at any time and she would respond to you. So we now are eager to hear her address. Thank you.
Good afternoon, everyone. Thank you so much, Rama, for that very kind introduction. Thank you, Usha, and colleagues for having invited me to join you today. And I hope that the discussions yesterday went well. And I'm sorry I wasn't able to join you yesterday. I think that this topic remains very important, not only for India, but globally. Maternal and child nutrition continues to be a challenge. We have not really achieved the targets or goals that we had set for ourselves. And while there's been progress made in many areas of health, I think this is one area that is still lagging behind, and we can discuss some of the reasons why this may be so. At the World Health Organization, obviously, we collect data from all over the world, track the data, as well as develop guidelines, norms, and standards, and also have a monitoring function. The science division, Rama mentioned that it was created in 2019. I became the WHO's first chief scientist, and it's a very exciting journey to have created this new division, to lay out its vision and its goals, and really focusing on the advances in science and technology that we can be leveraging in order to solve some of our health problems. There have been, as we've seen during COVID, but even before that, science can really help us to find the solution. So we have to use science, research, data, innovation, and digital tools to help and support us in this journey, whatever the goals may be. We need to use it well and use it wisely. And the other big lesson for me, I think, is that there is a lot of inequalities in our societies everywhere around the world. And the inequalities have been further brought out and exacerbated by the pandemic. So if the inequality index that used to be measured, if we continue to measure that, you will find that the disproportionate impact of the pandemic on the poor, on the marginalized and the vulnerable is going to lead to sort of a downstream impact on other health conditions, particularly on poverty. And poverty is always associated with nutritional disorders, as well as diseases like tuberculosis, for which, of course, I have worked for many years in my life. So I'm really worried that even if the COVID situation improves and we don't get any further serious variants, that we will continue to see the impact of the pandemic for many, many years to come. Also on the educational side, we have seen the closure of the schools, which has happened over the last 2 years in many countries. Particularly developing countries kept the schools closed for much longer than developed countries. And so we will have an impact on those children. Many children may not come back to school, unfortunately. They have already been sent to work, or girls have been married off. And it is going to take a huge, huge toll on these children the children who are now between the ages of 5 and say 20 or so, for their future careers. So I think we have to think really about our human capital. And if we want to invest in our human capital, then without good health, without nutrition, and without education, we cannot build a human capital, whichever country it is in. And the countries that have done well, countries which started off very poor, in the 50s and 60s, we have seen many countries in Asia, East Asia, which have invested in health and nutrition, and particularly invested in primary healthcare and primary nutrition, school age education with nutrition programs. They are the ones who have actually been able to build their economies. So I think that fundamental understanding of how these are linked, and that this is not a cost. Putting money into nutrition or money into health, it's not a cost for governments. It's an investment. It's an investment in building human capital, which will pay off many, many more times in the future. It's like preventing pandemics. You need to invest. We estimate you need about $30 billion a year globally invested in pandemic prevention and preparedness. If you do not spend that, then the cost of the pandemic is in the trillions of dollars. So unfortunately, it is very difficult to get governments to invest in prevention. It is an invisible sort of investment. If it is successful in preventing public health emergencies, then the public never sees that investment. It's all happening in the background. But you only see it, or the lack of it, when an epidemic or a pandemic breaks out. And then there is all of the soul searching that happens. So what we call cycles of panic and neglect and have happened. The whole world knew that a pandemic is possible. We didn't know which virus it would be, but it is always known that at any point you can have a pandemic due to a respiratory virus. And yet, we didn't prepare. But I think COVID has taught us many lessons, and we have learned many things. And so at least now we should be putting those into practice. So coming back to the topic of maternal and child nutrition, we know that malnutrition continues to affect millions of people in the developing world in LMICs, whether it is stunting, undernutrition, wasting, and also worryingly obesity. And the prevalence has remained unacceptably high. And as I mentioned, the status of food insecurity that FAO and WHO produced showed actually that the number of hungry people in the world has increased for the first time in many decades. We still have about 150 million children under 5 who are stunted, about 50 million who are wasted, and 40 million who are overweight. And of course, there is a lot of difference between regions and countries. And now when we see rising food prices, inflation, people have lost their livelihoods and jobs. Those are all, and of course now the war in Ukraine will all add on to the stressors that we already have in global food prices. And so there's likely to be a situation where things get worse before they get better. India is a paradox because our economic growth has been accompanied by alarmingly high levels of hunger and stunting, chronic hunger. The most recent Global Hunger Index 2020 ranked India 94th out of 107 countries, way behind some other developing countries. And new data now from the NFHS, so on, suggests that while less children are dying, so we've made a lot of progress in reducing maternal mortality, under 5 mortality, but those who survive perhaps are becoming more malnourished and anemic. In fact, the NFHS 5 showed worsening of nutritional indicators, especially in children under 5 years, and both increase in stunting and wasting in about half of the states that were surveyed. So that actually is extremely worrying. And at the same time, we're seeing that while you have wasting and stunting going together in some states, you also have obesity. Luckily, not very high still in children, but certainly in women, particularly in urban areas, obesity is increasing. Intergenerational malnutrition has been our biggest problem. Low birth weight babies give rise to small women, small mothers. They in turn give rise to low birth weight babies. So this intergenerational cycle, is bad, and it also results in an increased incidence of non-communicable diseases in later life, because we know that if you're born small for date and then you're exposed to more of calories in later life and become obese, then your chances of developing these diseases like diabetes and other non-communicable diseases is extremely high. What was also very worrying when looking at the NFHS data is the increase in the prevalence of anemia, both in women of childbearing age as well as in children, 65, 67%. And this actually must really raise any questions, and the nutritionists must address the question of why, despite a massive iron and folic acid program, as well as deworming program that states have implemented for many years now, why is anemia not reducing? Why is it increasing? Actually, it's going in the opposite direction. And you need good research to answer that question. But to me, a very simple explanation would be that iron and folic acid alone are not enough. You need a balanced diet. You need a complete diet, which has protein and fat in addition to carbohydrates and all of the different micronutrients. And we have known for a long time now that micronutrient deficiency is a bigger problem in India than macronutrient deficiency. And thanks to the PDS and other such interventions on food security, we do not have the kind of hunger that we used to have before. There is enough to feed people, and people are getting their cereals from the PDS. But what they're not getting is the other components for balanced diet, mainly the protein, the fat, and the vitamins and minerals, which come from a balanced diet, which come from having enough fruits and vegetables. And I think we know from repeated surveys, including those done by the NIN, that 90% of children do not get what would be considered as balanced and a complete diet. So I think that's our biggest problem and challenge, is that most Indians are not getting enough diversity on the plate of food. Just touching on the global targets and actions. In 2012, the World Health Assembly endorsed global nutrition targets, the WHO Global Nutrition Targets 2025, which provide concrete goals against which assessments can be made and malnutrition can be measured. And if you look at those goals, basically they talk about a 40%. This is by 2025, we have to achieve a 40% reduction in the number of children under 5 who are stunted, a 50% reduction in anemia of women in reproductive age, 30% reduction in low birth weight, no increase in childhood overweight. So we have to keep it stable. We have to increase the rate of exclusive breastfeeding up to 6 months by 50% and reduce and maintain childhood wasting to less than 5%. So these were the 6 targets around global nutrition. And I must say that it's going to be very difficult. As I mentioned, there are things which are going now in the opposite direction. Stunting, wasting, anemia are all heading in the wrong direction now. We also have these global non-communicable disease targets for 2025. Things like reduction of salt in the diet by 30%, halting the rise in diabetes and obesity, and reducing the prevalence of hypertension in the community. And if we are able to reach these targets, then of course we will be contributing to the SDGs 2 and 3, that is reducing hunger, achieving ending hunger rather, achieving food security, improving nutrition, and addressing all forms of malnutrition for all age groups, and ensuring health and well-being for all at every stage of life. That's SDG 3. And SDG 2 is around ending hunger and achieving food security. Now, we know that we have now less than 8 years to achieve the SDG targets, and because of the pandemic, we are sliding back. Even though SDG 2 and 3 are most directly connected with nutrition, 12 of the 17 SDGs have indicators that are highly relevant to nutrition. And that's really the fundamental issue, that nutrition is a topic that cuts across many, many sectors. There are many, many drivers and levers of nutrition. We know by looking at the recent data that we will not be able to meet the WHO 2025 global nutrition targets, particularly related to maternal anemia, overweight, diabetes, and obesity among adults, but also recently now in the child under 5 indicators were doing better, but now we have setback in those as well. And progress has been very slow in many low and middle income countries. We also have to, as I mentioned earlier, the important influence of early life undernutrition, particularly in combination with later excessive weight gain, leads to these pro-inflammatory and non-communicable diseases. And they have similar causes, overnutrition and undernutrition. As I mentioned, the underlying cause is an imbalanced, inadequate diet with not enough dietary diversity. So what is the solution to this then? The solution is we need a more comprehensive and holistic and a life course approach. There is no point saying we will give iron and folic acid tablets to pregnant women to try to solve the problem of anemia in women, or we will deworm children under 10 or under school-age children in order to solve a certain problem. So we need to think about the life course starting from birth to old age, and what are the nutritional needs and requirements at different ages and stages of life. And we also need to think about both delivering services through integrated primary healthcare approach and also thinking about what actions are going to be needed in the other sectors. So let us look at this, because healthier populations are achieved through multi-sectoral actions, which are not limited to health systems alone. Though the stewardship and advocacy and regulatory functions of health ministries are important, but health ministries do not control many of the actions that are needed. And optimal nutrition for individual health and development bridges the interventions by health systems to improve the health of populations. So in 2019, the WHO actually produced a publication that compiled the actions to address malnutrition in all its forms. It was done in a user-friendly and concise format in addition, so as to aid decision-making processes for integrating nutritional interventions within all different national health strategies, policies, and plans based on the local priorities and needs. For example, when you think about NCD program, you have to think about nutrition and diet in order to have a more sustainable effect. You think about a tuberculosis control program, you also have to think about the accompanying malnutrition that goes with it. And I'm very happy that when I was in ICMR, we were able to launch studies to show the impact of supplementary nutrition on TB, not only on the TB patient, but on the household contacts, because we know that household contacts within TB patients' homes are at very high risk of getting TB. So this study that was undertaken in Jharkhand has provided a lot of data, which is quite worrying. For example, the average BMI of a TB patient in Jharkhand was something like 14. And as you know, an average BMI should be between 18.5 and 22 or 23 for a healthy adult. And many patients with TB had BMIs of 9 and 10, which actually we think are incompatible with life. And yet these tribals in Jharkhand, when they get TB, they're already at a very low undernourished state, and then they further lose weight. So the household contacts are of a similar nutritional background. Therefore, by giving a nutritional support to these families with rice, dal, oil, as well as other source of protein like soya or peanuts, we were looking to see whether you could actually improve the nutrition status of these TB patients. And they did improve. They were able to go back to work much more rapidly. And the household contacts also received this supplement. Their nutrition status improved, but I don't think we were able to show a difference, or the study were not able to show a difference in TB incidence rates, because you need a very large study to show that. But it did show the need, and the qualitative studies that were done with these tribal families showed how food insecure they are at normal times. And certainly when they are impacted by TB, then everything gets worse. So this is why I think strategies really need to think about nutrition, whatever the strategy is being rolled out. And as I mentioned, it's a life course approach. So even care and support for the elderly, which is becoming more and more important in countries like India as people are living longer, need to address the nutritional needs of elder women, elder men, and make sure that those are taken care of. So we know that the early childhood nutrition is extremely important. We've talked about the first 1,000 days, not just for that period of life, but that has an impact on the entire life. And as I mentioned earlier, the human capital and the development of the brain, the growth of the brain is maximum in the first 1,000 days of life. And if that child is not getting adequate nutrition and adequate stimulation and a good environment, which also includes things like water, sanitation, and housing, then there are studies again done by Dr. Gagandeep Kang and others in CMC Vellore that have shown that children who grow up in an insanitary environment, in the slums, etc., even if you feed them well, they still suffer from a chronic enteropathy, which leads to malabsorption and undernutrition. So again, it's not the feeding alone, but it's the environment in which a child is living, which can allow that child to thrive. So we know that we have to move from child survival to child thriving, because ultimately, if you don't have a thriving child, you will not have a healthy adult. So how can we take a more holistic and integrated approach to provision of health and nutrition services? And this is the action items that WHO had produced, essential nutritional actions for healthier populations over the life course, starting from a healthy diet, which is across the life course. Everybody needs a healthy diet. And the sectors which are involved, other than the health sector, are agriculture, education, trade and industry, because they can determine. We talk about the commercial determinants of health, commercial determinants of nutrition. We know that even poor people today, they buy and they eat things which are available easily from shops, and most of those easily available packets are high fat, high sugar, high salt, and lacking in other nutrients. So we need to address all of these Interventions on the agriculture side, intervention on the trade and industry side. There have been many examples where global trade practices have also impacted the nutrition status of communities, unfair global trade practices. So those things all need to be looked at. Then when you look at infants and infant nutrition, there are interventions like the optimal timing of cord clamping, particularly in preterm children. You know that if you have delayed cord clamping, you can improve their anemia status. Then breastfeeding, care of low birth weight and very low birth weight infants, management of wasting, and the vitamin A supplementation for children under 6 months. These are targeted interventions done by the health sector, but the breastfeeding aspect, promoting and supporting breastfeeding has to be done before and after the delivery. Then in terms of children's nutrition, you have, of course, the complementary feeding, growth monitoring and assessment and managing of wasting. And again, here, the education sector becomes very important because of the interventions that are done in preschools and schools, as well as trade and industry. And so on, you can go through in children. There are iron-containing supplementation, vitamin A supplementation, iodine, zinc during diarrhea. And then for adults, you have the nutritional care of women during the pregnancy and postpartum, as well as iron, iodine supplementation. And then I mentioned the older people and the other groups, like people with HIV, people living with TB, feeding of infants who are carriers of diseases like hepatitis B, etc. And then now we are seeing a lot of global emergencies. And so nutrition during in humanitarian settings also is an important. So we have to think of all of these situations during the life course that can happen. What are the interventions that can be done by the health sector? And again, when I talk about health sector, it's like primary health care, which is not only treatment of disease, but is promotive health, preventive health, then the curative aspect, then rehabilitation and palliation. We have to think of all of these aspects when we talk about primary health care. Then there are many, still open research questions that need to be addressed. There are interventions which have a strong evidence base already, like kangaroo mother care, particularly for preterm and low birth weight infants. We know that it improves child survival. Breastfeeding, we know, complementary feeding, vitamin A. Many of these things we know. Large-scale food fortification for prevention of micronutrient deficiencies. Again, the food fortification is a controversial subject, but ultimately what is a sustainable one really is having a dietary diversity, biofortification of foods, promoting the use and the consumption of locally available nutritious foods. And so, because Rama is here, I want to mention the work that she did with the MS Swaminathan Research Foundation on building nutrition literacy in communities, empowering mothers, empowering the women, and about the best feeding practices for the family as a whole, because you empower the woman with nutrition information, the entire family will be fed a balanced diet, provided, of course, that it is also affordable. And that's why focusing on locally available foods, expanding the PDS basket beyond just what is available today to include elements from where people can get micronutrients. Can we not promote the sale of local vegetables, green leafy vegetables, and seasonal fruits, not expensive fruits, but things like guava and papaya and lemon, which grow everywhere, and the different types of greens that we have in every community, in every place. The greens have been part of Indian diets, but because it's maybe not affordable, not available in urban areas, how can we promote urban horticulture? How can we set up these nutrition gardens? There are spare, land lying in schools, in Anganwadi centers, and even in slum areas. You can promote the growth of locally things which can grow easily but are nutritious and provide a day-to-day intake for the local communities living there. We have to think of solutions like that, not purely biomedical solutions like feeding people tablets of iron and folic acid. That is also necessary. but that is not going to solve the problem of nutrition at the population level. That can only help the individual who has been targeted for. So research is very important. As programs are being rolled out, as programs are being, new programs are developed and rolled out, building in research into that, learning from it, adapting, dropping the interventions which are not proving successful and trying out new ones is extremely important. So adaptive learning within large-scale nutrition and social protection programs is important, especially learning what is not working and changing that. And we need, there are many service delivery innovations that have now been used. There's telemedicine, telehealth, the use of mobile apps, mobile phones, contacting people remotely, having virtual sessions on nutrition literacy. There could be many new ideas which can be incorporated into nutrition programs in order to improve outcomes. But of course, it's really important that all actors and sectors outside the health sector also get involved, particularly, as we mentioned, trade, industry, agriculture, education, women and child development, and of course the planning, the Niti Aayog and the other planning bodies at the state level will need to be involved. But again, this is a time actually to think about the innovative solutions which can be implemented and have a longer term sustainable impact, at the same time promoting the other sectors like local agriculture. So linking up agriculture, nutrition and health is really, I believe, the way to think about the future. It can also address the issue of climate change, because many of the nutrition-rich plants actually are also climate resilient and can be grown by farmers. So the right kind of advice needs to be given. And of course, then it's not just enough to grow the farmers, you have to procure and then be able to distribute and give them a fair price for what they're producing, and then make it available through the PDS. There are a few states which have made millets available through the PDS. Tamil Nadu is one of the states that I think announced in the last budget that it would do so. So it's policy changes like that which can actually start making a difference, apart from the fact that we need to also continue to motivate and empower and educate people on the importance of some of our traditional diets, which were quite well balanced, which have been replaced by diets which are either just based on cereal or on commercially processed foods, and that is not going in the right direction. So I would like to leave you with those thoughts, and I hope that the Nutrition Society of India can really advocate for this type of approach, both a life course approach, multi-sectoral action, and actions which involve and empower local communities and build on local knowledge. Thank you very much.
Thank you, Dr. Soumya. It was wonderful listening to you. And I think your talk really re-emphasized the need for more research in nutrition and healthcare, and emphasizing on micronutrients and eradicating iron deficiency. Although we are trying, I think we need to really think of it in a broader perspective, and also focusing on a holistic approach to reduce micronutrient deficiencies, and not just supplementation with iron or folic acid, and to think about actually giving people a balanced diet. I think it is really important. And this is also important to overcome energy deficit as well as excess. And focusing on eating right is, I think, the most important aspect that as nutritionists we need to focus on. Thank you so much for being with us today, sparing your time. And I know you are really, really a very busy scientist at the global level, and you found time to be with us today. Thank you so much, ma'am. And we were just very extremely happy to have you with us here. Thank you for all your time.
Thank you very much.
Thank you so much. Thank you.
Thank you, ma'am. For the past 2 days, we've been having a lot of deliberations about the need to give proper adequate nutrition to the mother as well as to the young infant. And we know that there are a lot of challenges also we face while, we attempt to do so. So I gladly invite Dr. Gauri to introduce our next speaker for the day, Dr. Praveen Kumar.
Thank you, Lakshmi. It's my pleasure to introduce Dr. Praveen Kumar, with whom I have been corresponding. Thank you, Doctor, for being here with us today. And He is the director and professor of pediatrics and deputy lead coordinator at Lady Hardinge Medical College and associated Kalavati Saran Children's Hospital at New Delhi. He is also the lead coordinator of the National Center of Excellence for Management of Severely Acute Malnutrition. Given his interest in nutrition research and pediatrics, it is of no surprise that he has delivered a lot of programs and talks at the national and at the international level on integrated management of newborn and childhood illness, care of severe acute malnutrition, then infant and young child feeding programs. And he's also contributed in the development of national child health programs and training guidelines such as facility and community-based management of children with severe acute malnutrition. He is a member of Global MAMI Steering Committee, and Dr. Praveen Kumar is also a technical group member for Government of India on nutrition and diarrheal programs. So I think we have an excellent resource person with us today who's going to deliberate on management of acute malnutrition in the first 6 months. Welcome, Dr. Praveen Kumar. Over to you now. Thank you, sir.
Yeah, so thanks a lot, ma'am, for the invitation, and please confirm whether I'm audible and my slides are visible, ma'am.
Yes, sir.
Yes, sir, you're audible, sir.
Yeah, okay. Right. This is a topic which is really coming up, and in the previous session we have learned about the importance of first 1,000 days. So I will be talking about management of acute malnutrition in infants under 6 months. So to start with, why we need to talk about this, and why we need to take care more intensively for particularly infants during first 6 months. This is because this is now increasingly being recognized that infants less than 6 months, many of them, they are malnourished. And this is what you see, particularly if you compare different age group. So what we realize that less than 6 months, almost 1/3 of our infants, they are usually, they have wasting. And even severe wasting is quite high in this age group, to the tune of almost 15%. So this is as per NFHS 4, and at this point of time, I do not have data from NFHS 5. Dr. Swaminathan ma'am has already highlighted importance of first 1,000 days of life. We all know this is the critical time when the brain development happens. There are synapses, and there is increased synapses maturation, and most of time, if there is malnutrition during this phase, this ultimately will be affecting the child's mental growth, and this also will be affecting adulthood productivity. It's also important from survival point of view. This is one of the study where they reported that the mortality is higher in infants under 6 months if they are severely acute malnourished. So this is just to compare the infants under 6 months with severe acute malnutrition survival as compared to older children. So far, most of our health programs, they are usually taking care of acute malnutrition in infants and children beyond 6 months. But we do not have any existing program or any government strategy per se for identification of malnutrition in under 6 months. Although we have several platforms which has potential to identify, which I will discuss in my subsequent slides. So what we all will agree that in absence of adequate support, infants with growth failure, they are at higher risk of mortality and also developmental delay. So if we try to see what are the risk factors, why these under 6-month infants, they are becoming malnourished or they develop growth failure. So we have several risk factors. A lot of infants are low birth weight. There are major contribution of faulty breastfeeding practices. There is also a group of infants where we have recurrent infection, certain neurological problems like cerebral palsy or some other problem, congenital anomalies interfering with feeding, and also there is a contribution of maternal depression, social conditions interfering with breastfeeding, which is largely we do not give due attention to this component, which is the maternal depression. And all these factors, what they ultimately lead to is infant do not suckle at breast effectively. This leads to less milk production, less nourishment, and growth failure in infants under 6 months. So first time in 2013 update, WHO also recognized this, particularly malnutrition during first 6 months as one of the important area which needs more attention. And they identified that increased mortality in this age group are likely to have because of if they have recent weight loss, if they fail to gain weight, if there is failure to feed effectively, and the presence of bilateral pedal edema. And they also defined high-risk infants under 6 months. If these infants were having any general danger sign as per IMNCI, or they were having poor weight gain in spite of nutritional counseling and support, and all infants fulfilling the definition of severe acute malnutrition, that is weight for length less than -3 standard deviation and bilateral pedal edema. So in 2018, we started working in this area regarding the management of under 6 months under the able guidance of late Professor M.K. Bhansar. And this was the first meeting which we had in October 2018 on how to identify and how we should manage acute malnutrition in infants under 6 months. Then we came across this global CMAMI tool, which is community management of at-risk mother and infants under 6 months. And in this, there are algorithms, and they first talked about how to identify and the classifications, how to categorize infants under 6 months with acute malnutrition into different categories. So now this is the global MAMI care pathway, where I am also one of the members. And this MAMI care pathway tells you about the management of a small and nutritionally at-risk infants under 6 months. And it is modeled on integrated management of childhood illness, IMCI approach. In our country, we know this as IMNCI, which is based on WHO IMCI. So this pathway has simple algorithm where we have first screening, then we assess and diagnose, and then based on classification, we manage and treat. So as I mentioned, there are several potential platforms existing. We have where we can utilize these contact points, which is pre-pregnancy, during labor, birth, early postnatal period, and several other points we can utilize. I will discuss this in more detail. So in this approach, what you do, you first look for IMCI danger sign. If there is no IMCI danger sign, then you look for additional risk factors. If there is IMCI danger sign, they are directly sent to hospital. And if the child has moderate risk, then they are managed at community level with trained health worker. So that is the approach we have. There are assessment forms for these clinical signs, symptoms, and also they have suggested maternal mental health assessment form by asking few recent questions regarding last 2 weeks, and based on this assessment, we usually have some grading and we identify mental health problems, whether they are high risk, moderate risk, or low risk. And then we have certain growth parameters which we record of the child, and some other risk factors. So based on this, we tried to adapt this MAMI approach for India. And in 2018, as I mentioned, this was the first meeting which we had. And then in 2019, we developed some algorithm, and which was finalized with the help of experts. As I mentioned, there are existing programs and services for infants under 6 months, which if we are able to utilize, then we will be able to identify these high-risk infants. So we have SNCUs for care of particularly preterm and low birth weight babies less than 1,800 grams, where they are coming for follow-up. We have home-based newborn care HBNC program. We also have recently launched HBYC program, where we have 5 follow-up additional visits. And then we have a MA program to improve breastfeeding practices and scaling up of training. Then we have village health and sanitation and nutrition days, where we have frontline workers. They usually have convergent action for health, early childhood development, nutrition, and sanitation. And then we also have nutritional rehabilitation center to manage severely malnourished children. So there are already services. We do have for mothers also, Janani Sishu Suraksha Kajkram. We have ICDS services. We also have village health and sanitation at community level, where we can provide services to mothers. So these are the contact points in HBNC. The frontline health workers, ASA, they visit on day 1, day 3, day 7, day 14, day 21, 28, 42. So there are several these time periods when they usually have home visits. For institutional deliveries, cesarean deliveries, all these are recommendations. But whether we are able to utilize this, can we utilize these contact points for identification of infants who are not growing well, where we have growth failure? So that is what we have to decide. Similarly, for Ministry of Women and Child Development, also we do have several visit points. So what we are trying to do, using this with simple algorithms, we have suggested that each these contact points should be utilized, And we can classify infants under 6 months into 3 categories. One group is where the birth weight is more than 2.5 kg. They are exclusively breastfed. Their growth parameters are normal. They have gained adequate weight, and there are no maternal and nutritional or psychosocial issues. This is the group which is classified as not at nutrition risk. Here, they should be praised and general information is adequate. While moderate nutrition risk, if they have moderate or severe malnutrition, if the baby has not regained birth weight by day 14, or they have a static weight between 2 consecutive visits even after nutritional counseling, or there is any breastfeeding or feeding problem, and if the baby is not breastfed, also try to look into this group, whether they are able to prepare milk correctly, whether they are using bottle and all these issues. And the third is where we classify at severe nutrition risk. If they have any severe illness or birth weight is less than 1800 gram, or there is weight loss between 2 consecutive visits, or there is sudden loss or sharp drop across the growth curve line, or there is a congenital abnormalities. So this is the way we have classification. Most of time, problem is due to no problem in breastfeeding or feeding problem, where we need to, or these frontline workers, they can observe, they improve positioning, attachment, and then review whether this child has gained weight or not. We know we need good attachment and positioning. We need to identify any hindering factors which is there for breastfeeding, and we need to correct them. So that is what is there. If we are able to identify them, correct them, provide support, then we expect a large number of them, they will have adequate weight gain. And the main focus is on improving attachment, positioning, and all these issues. If the baby has not gained weight after improvement of attachment and positioning, then the health worker may try this cradle hold method or cross cradle hold method, whichever the mother is comfortable, and then a significant number of these additional children, we will have adequate weight gain. At the same time, the other group is low birth weight and SNCU graduate infants, where we have to again provide support, support exclusive breastfeeding. We have to advise and support them to continue with kangaroo mother care, nutritional supplement which is recommended for low birth weight babies, and we have to tell them regarding other important child caring practices like family planning, immunization, nutritional care. So these are the things which we have to discuss. For low birth weight babies, there are certain nutritional supplements which is recommended, and we have to help families to continue this. We know there are several advantages of continuing care, and the frontline workers, they should support mother in continuing this. So to summarize what all we have in this approach, we try to identify growth failure in infants less than 6 months, try to identify breastfeeding problem. If there is low birth weight, this child is going for inpatient care, or if we have a static weight and if the baby is not improving, then that also will be going to inpatient care. And for services, we have these contact points where that will be utilized for providing services from birth to 6 months. So this is the new approach which we are just trying to implement in few of the states. In this year, probably we will be able to pilot in few of the states. And that will help us to fulfill the dream of this every infant under 6 months. They are assessed at every community and health service contact points. We are able to nutritionally assess, and we are able to appropriately support so that all of them, they are able to survive and thrive. So thank you very much. This is what I just wanted to share with you. Thank you.
Thank you for the enlightening talk, sir. Your presentation was very interesting. And although we talk a lot about the importance of breastfeeding for the first 1 year or so, a lot of mothers are still reluctant to follow breastfeeding practices. So, and you've taught us a lot about the factors that are responsible for growth failure, as well as the recent developments, the services that is being offered, as well as the recent developments that are there to prevent growth failure. Thanks a lot, sir. Sir, we have a question in the chat box, sir. Can I ask you about it, sir?
Yeah. So I think, ma'am, she has asked about the supplements. So as I mentioned, low birth weight babies, we have to supplement calcium and vitamin D, which is recommendation as per our country's guideline. So that we have to ensure that the mother is continuing these supplements as advised from the doctors from special care newborn units. That is what I mentioned.
Thank you, sir, for answering the question. Good nutrition during infancy and early childhood is essential to ensure the growth, good health, and development of the child to its full potential. Complementary feeding helps guarantee it. We have with us Dr. Sharika Yunus to enlighten us on the challenges in complementary feeding under special circumstances. I would like to request Dr. Meenaka to introduce Dr. Sharika.
Good afternoon to one and all. On behalf of the Nutrition Society of India, Chennai chapter, it's my honor to introduce Dr. Sharika Yunus. Madam graduated in medicine from the Jawaharlal Nehru Medical College, Aligarh in 2001. She is a gold medalist in community medicine, and subsequently she did her post-graduation in community medicine from the same college in 2005. She holds a diploma in public health nutrition from the Public Health Foundation of India, and has also been trained on the management of nutrition emergencies by the University College of London and Asian Disaster Preparedness Center. She has worked on the ASHA project under the National Rural Health Mission with the training division under Ministry of Health and Family Welfare, Government of India. She has also worked as a focal point for nutrition at the World Health Organization Country Office for India. And currently she is working as the head of nutrition and school feeding unit at the World Food Program Office in India. She has to her credit several research papers in various national and international journals. Her main areas of interest are maternal and child health, infant and young child feeding, and links between disease and nutrition. Thank you, ma'am. Thank you for accepting our invitation. Over to the speaker.
Thank you so much for that extremely kind introduction and for giving the World Food Program the opportunity to present. If it's okay, I would switch off my video and move directly to the presentation. The internet connectivity at my end is not that great, so if that's okay, I'll start.
Okay, ma'am.
Sure. Just let me know once the presentation gets on the screen. Yes, can you all see the presentation?
Yes, ma'am.
Okay, excellent. So thank you so much for this opportunity. I have a very brief presentation, won't take too much time. But I do hope that at the end of it, we'll be able to have some questions, some solutions in terms of what is it that we can do to deal with the challenges of complementary feeding in our country. We all know that stunting is the primary indicator of childhood undernutrition. We are also all very well aware that stunting is largely irreversible after the first 2 years of life, and that adequate nutrition during the first 2 years of life is critical to ensure the optimal physical and mental development of infants and young children. Once it becomes irreversible, the damages are immense in terms of shorter adult height, loss in number of years of schooling, reduced adult income, and it therefore becomes a vicious cycle with the next generation, in most cases, also being stunted. We're aware that though it may be an issue, but the solutions for stunting as well as all forms of malnutrition are low. And the key to addressing stunting is maternal and infant young child nutrition. We're aware that the growth rate of fully breastfed infants in India, as in other developing countries, is fairly comparable to that from developed countries. But as the child grows and reaches the phase around which complementary foods tend to be introduced in our country, that is where we see a huge deviation between the growth rate of our infants in the developing countries versus those in the developed countries. And the lack of nutrient-dense complementary foods and frequent infections are the main factors accounting for some of this decline. Data has shown, as well as the Lancet series over the past several years, that infant and young child nutrition in the 2003 Lancet series on child survival, it ranked the top 15 preventive child survival interventions for their effectiveness in preventing under 5 mortality. Exclusive breastfeeding up to 6 months of age and breastfeeding up to 12 months of age was ranked as intervention number 1, while complementary feeding starting at 6 months of age was ranked at as a substantial intervention at number 3. Both the interventions put together are capable of preventing almost 1/5 of under 5 mortality in developing countries. The importance of infant and young child nutrition, both exclusive breastfeeding till 6 months of age, as well as timely introduction of complementary feeding, was also re-emphasized in the Lancet series 2008. Now, what are the guiding principles for complementary feeding? And again, for this audience, I do not necessarily need to re-emphasize, because I'm sure all of you know about the guiding principles for complementary feeding. The first being that there's a need to practice exclusive breastfeeding up to 6 months of age, and at 6 months of age, complementary foods are introduced while continuing to breastfeed. Breastfeeding needs to be continued on demand till 2 years of age or beyond, depending on the circumstances of the women. The complementary feeding needs to be responsive in nature and adhering to the principles of good hygiene and proper food handling. At 6 months of age, one should ideally start with feeding the child with small amounts of food and increase the quantity of the feeds that are given to the child, as well as the frequency of the feeds as the child grows older. The food needs to be nutrient rich so that all the nutrients of the child are met. There needs to be an emphasis on use of fortified complementary foods or vitamin minerals supplements for the infant as might be needed. Increased fluid intake, especially complementary feeding during illness, is a problematic area because the child is irritable, and of course the child is ill. All focus should be on increasing fluid intake during the illness period, including more frequent breastfeeding and encouraging the child to eat soft and some of the favorite foods of the child. And once the child feels better, then the emphasis should be on encouraging the child to eat more, in most cases, 1 extra meal. Now, let's have a look at the complementary feeding practices in our country over the years. Over the past, and what I have here is data over the past 15 years. The National Family Health Survey captures data on complementary feeding on 2 indicators. One is on children aged 6 to 8 months receiving solid, semi-solid food and breast milk. And this indicator gives a sense of the timeliness of introduction of complementary feeding. The second indicator is total children aged 6 to 23 months receiving an adequate diet. So if we look at the first indicator over the past 15 years, actually in 2005-06, when the NFHS 3 came out, about 52.6% of children aged 6 to 8 months were receiving solid, semi-solid foods and breast milk. This went down in NFHS 4 in 2015-16. And in the current NFHS 2020-21, we should seem to be improving. But what you can see is that between NFHS 4 and NFHS 5, though there's an improvement, but the pace of improvement is a mere about 3.2 percentage points over a period of roughly around 5 to 6 years. In terms of children receiving 6 to 23 months receiving an adequate diet, we are doing abysmally poor in that particular indicator. Only about 9.6% of our children between 6 to 23 months of age were receiving an adequate diet. This number went up in the latest NFHS round, though again, the rate of increase has been exceptionally slow. A minimal adequate diet, as per the World Health Organization recommendation, is a combination of dietary diversity and minimum meal frequency, and is different for both breastfed as well as non-breastfed children. Dietary diversity, when we try and measure dietary diversity, we're basically trying to look at the micronutrient adequacy of the diet. And when we're looking at minimal meal frequency, we're largely trying to focus on the energy and the caloric content of the diets which are being fed to young children. The details on NFHS 5, the detailed report is yet to come out. But what we know in terms of from the report available from NFHS 4, if we look at complementary feeding practices and we try and judge it against background characteristics of mothers and caregivers, what we know is that breastfed children aged 6 to 23 months are less likely than non-breastfed children in the same age group to receive the minimum number of food groups. The minimum number of food groups being 4. Children in urban areas are more likely than those in rural areas to have an adequately diverse diet. Breastfed infants are less likely to meet the minimum acceptable diets than the non-breastfed infants. And the percentage of children aged 6 to 23 months who receive a minimum acceptable diet tends to increase with the number of years of a mother's schooling. So more educated the mother, the more chances are that the child between 6 to 23 months would be receiving a minimum acceptable diet. This then sort of brings us to a summation of what are the causes of poor complementary feeding practices in India. And we know that there are undesirable socio-cultural beliefs in terms of what is the right age for introduction of complementary foods. Despite the guidelines being that complementary foods need to be introduced from 6 months of age, there are various limiting practices which lead to either too early an introduction of the complementary foods or a delay in the introduction of complementary foods. Maternal illiteracy, and we've also seen data as to how maternal illiteracy tends to impact complementary foods. There's ignorance and lack of knowledge amongst the mothers, the caregivers of the child. In fact, there's also been a recent study which was conducted by Alive and Thrive in one of the northern states of the country, which also tended to point towards the fact that even medical practitioners whose word is often taken as gospel truth as far as health and nutrition is concerned, also do not seem to have the right information to pass on to mothers and caregivers on complementary feeding. What we also know is that mothers, whether it's a rural setup or whether it's an urban setup, are always in this rush to get back to work because of various circumstantial issues. There's an increasing feminization of agriculture, and therefore we see more and more rural women getting back to the fields, getting back to agriculture to ensure that there's a continuity of income in families, with most of the men also being out to urban areas in search of livelihoods. This therefore means that the young child is often left either to the elder sibling or is left under the care of the elderly grandparents, who may again not necessarily have all the information related to appropriate complementary feeding. Caregiver attitudes and knowledge, as I've already said, it's an issue. People often do the wrong thing or the inappropriate thing because the correct information may not necessarily be available to them. In our rural setup primarily, though we have the Anganwadi workers, but the Anganwadi workers in terms of providing a space, they provide space only to children between 3 to 6 years. For the lower age group, they do provide services, but not necessarily at the Anganwadi center. So there's a lack of facilities for young children, especially in the rural setup. Even in the urban setup, there could be scope for improvement. Most of our frontline functionaries also do not necessarily have, especially the grassroots functionaries, the Anganwadi workers and the Ashas, may not necessarily have all the right information on infant and young child feeding. And oftentimes their training has been largely focused on breastfeeding. Between breastfeeding and complementary feeding, I think there's been a lot of emphasis on breastfeeding and not due emphasis on complementary feeding. And therefore, oftentimes the frontline functionaries also do not have the correct information to pass on to the community. One thing that I'd like to point out here, and that's an area of work that as the World Food Programme, we've been immensely focused on. That's around the take-home rations. So we're aware that take-home rations are being distributed to children 6 to 36 months of age, pregnant lactating women, as well as to adolescent girls. But what we see is, of course, there are issues around the quality of take-home rations, it not necessarily being an appropriate take-home ration in terms of protein quality, in terms of fat content, in terms of sugar content. But the most important fact is that the Anganwadi worker just sees her responsibility as passing on those take-home rations. While those take-home rations are being passed on to the caregivers or to the parents of these young children, this could be an opportunity for, passing on correct information around complementary feeding, etc. But this instance is just limited to passage of the product, and there's literally no information which is given on how the quality of nutrition could be improved using the product, or how complementary feeding practices could be improved, or how this product, if used appropriately, could also perhaps have a role in preventing malnutrition. In terms of challenges in complementary feeding in special circumstances, I largely focus on complementary feeding in emergencies. I think this goes to the fact that the past couple of years, the world has been in the grip of an emergency. Also, we do have several evolving emergencies in Europe with the Russia-Ukraine war going on. So I'll focus largely in the next 2-3 slides on complementary feeding and what is the global guidelines around complementary feeding in such emergencies. And the key considerations in determining complementary feeding response in such emergencies needs to be considered based on what is the pre-existing and existing nutrient gaps, what are the socio-cultural religious beliefs in that particular context, what's the available access to appropriate foods, what's the quality of locally available complementary foods, what's the availability of commercial products, how does all of that comply to the breast milk code and to the WHO guidelines on ending inappropriate promotion of foods for infants and young children. So a lot of these factors need to be considered before guiding countries on how to implement a complementary feeding response in emergencies. And of course, in most countries, this is supposed to be led by governments. The complementary feeding response that could be introduced in emergencies could be a plethora of options. It could be cash or voucher schemes to purchase nutrient-rich foods, or fortified foods that are locally available. It could, in some circumstances, also boil down to the distribution of nutrient-rich foods or fortified foods at the household level, and then teaching the caregivers on how it could be converted into an appropriate complementary food for young children. It could also be focused on provision of multiple micronutrient fortified foods to children 6 to 23 months and to pregnant lactating women. Could also be focused on distribution of micronutrient powders. In some contexts, it could evolve as a livelihood program or a safety net program for families with children under 2 years of age. And because it involves preparation of complementary foods, the response should ideally also include provision of non-food items and cooking supplies, access to food preparation areas, especially where household facilities are lacking, and advice on food safety and handling. The other principles to consider are that if for any reason commercially produced complementary foods are being used, then those commercially produced complementary foods must meet the minimum standards on nutrition and food safety. However, in all circumstances, the focus should be on prioritizing in-country familiar quality complementary foods over importing new products. It should also be ensured that all complementary feeding interventions, and I think no one can emphasize this just enough, that all complementary feeding interventions should protect and support appropriate practices by providing context-specific advice and how the foods which are provided could be adapted to feed different age groups, and to ensure that it all complies with the WHO guidance and the in-country code which is applicable. With that, that's the end of my presentation. In case there are any questions, happy to take them.
Thank you, ma'am. There is one question in the chat box, ma'am. Ma'am, kindly can you take up the question, ma'am?
Ma'am, should I read it out to you, ma'am?
No. Ma'am, in terms of adequacy of feeding, what do you think the reasons could be for the rural-urban difference?
I think for the rural-urban difference, perhaps availability is one of the issues, that perhaps the availability is much more in the urban areas. Also, the knowledge and the awareness perhaps could also be a bit more in the urban areas. So I would perhaps think these two areas could point to the difference between why we see better complementary feeding practices in the urban area compared to the rural. Over.
Thank you, ma'am.
I have a question. Menaka?
Yes, ma'am. Yes, ma'am.
I have a question.
Yes, ma'am.
Yeah, Dr. Yunus, how much of this divide which you had mentioned also is because of the lack of purchasing power? Can part of it be explained by a difference in the purchasing power between the urban and rural areas, or is it, of course, it's multifactorial?
Yeah, absolutely. I think when I say availability, I would also include purchasing power as one of the determinants on availability and access. So I completely agree with you, ma'am. I think purchasing power is another area or one of the reasons why we see this divide between the rural urban. So completely with you there.
Thank you. Thank you.
Thank you, ma'am, for the thought-provoking lecture that you had just given us. And thank you for graciously accepting our invitation and joining us today, ma'am. You had given us some very key important points about the different support systems that can be provided in case of a difficult circumstance, like for example distributing nutrient-rich foods or for introducing livelihood programs to families and all those things, and also that we have to follow the WHO guidelines or standards that's been provided when we provide a complementary feeding intervention. Thank you so much, ma'am.
My pleasure. Thank you so much.
Thank you, ma'am. The government has introduced various schemes for mothers and for young infants at both the national and the state level. To enlighten us on the topic, we have with us an intriguing person, none other than Tirumadi Amudavalli IAS. I now request Ms. Anita to introduce us to Ms. Amudavalli.
Anita is not able to unmute. Will you unmute?
Yes, ma'am. Yes, ma'am. Let me check.
Thank you, ma'am. Am I audible?
Yes, ma'am.
Yeah. Good afternoon to everyone present here. It's a great privilege for me to introduce the very renowned person, Tirumati V. Amuthavalli IAS. Amuthavalli IAS is an Indian Administrative Service Officer of Tamil Nadu cadre who is currently working as a Director cum Mission Director in Integrated Child Development Services. She was born in Madurai and started her career as Deputy Collector in April 1997. Initially, she was appointed as Deputy Collector of Tiruvallur District in Tamil Nadu. She has served in various departments under Government of Tamil Nadu like Cooperation, Prohibition and Excise, Municipal Administration and Water Supply Department and Industries Department. While working as a Director of Social Welfare, she received the prestigious Nari Shakti Puratskar Award from President of India in 2018. While serving as Director and Managing Director of Tamil Nadu Tourism Development Corporation, she was awarded Guinness World Record title for World of Assembly, largest number of classical dancers on single floor. We are eagerly waiting to hear you, ma'am. Thank you.
Hello, good evening. Can you hear me?
Yes, ma'am. Yes, ma'am.
Can I see the presentation, please?
Yes, ma'am. Just give me 1 minute, ma'am.
Good evening, all of you. I hope I'm audible to all. And I'm really, I have immense pleasure in addressing this August gathering on the government initiatives. So in addressing malnutrition, nourishment among children, and what are the government initiatives and how government really cares for these children under this Integrated Child Development Project scheme. This I want to share, and this will take maybe another 15 minutes. This presentation will go. Next slide, please. Can I operate the slide or somebody is helping?
Ma'am, I'm doing it for you, ma'am. So if you can ask me to change the slide, I'll do it for you, ma'am.
Yeah, next, please.
Yes, ma'am.
Actually, Integrated Child Development Project is a scheme which has this objectives. Our basic target groups of beneficiaries are first pregnant women, and then lactating women, and then children till they attain the age of 6 years. And also we have some schemes for adolescent girls between the age group of 11 to 14. So what we aim is to improve the nutrition and health status of the children under 6. And we want to have ensure that the development of children happens in a holistic manner. Reduce morbidity, mortality, and malnutrition among children. And we also work in coordination with other departments, especially health and education, to promote child development. And we also focus, our scheme is to focus on the maternal health. Next one, please. So we offer the following services. So early childhood care and education is after their children attain the age of 2 years. For 2+ children, we have designed an exclusive curriculum, and we have a month-wise syllabus pattern, and we print the books, and these books are available. And these syllabus are available in all the Anganwadi centers, and the Anganwadi worker really takes care of the early child care and also the development, just preparing the babies to attend the regular school program. We focus on supplementary nutrition, immunization, health checkup, and for children who need some special care, so severely undernourished, severe underweight, or some disabilities, early intervention is required, we do the referral services also. And we focus on the nutrition and health education for all the 4 groups we have already mentioned. Pregnant women, lactating women, adolescent girls, and also children under 6. Next, please. So this is where we stand. This is our report card. So I have just given a comparison of NFHS 4 survey report, NFHS 5 survey report recently published, and Portion Tracker is an application right now currently we depend on, which reflects the data on real-time basis. That is, every Anganwadi worker has a mobile phone and this app installed in it. And in their area, they monitor the growth of the children who are enrolled in under ICDS and the various indicators of stunting, wasting, underweight, anemia. These are all, anemia is not monitored in Portion Tracker, but all the other things are being tracked. Every month, all the children are supposed to be measured for their height and weight and determine the growth, whether they are normal children and if they are stunted or wasted, what additional supplementary nutrition can be given to lift them and bring them back to the normal records. So this is our report card. So we can't, I don't feel pride in that Tamil Nadu is performing better than the all India average, or we have performed better than 4 survey report. But what we aim is for a state like Tamil Nadu, which has been comparatively working very hard from the 70s to eradicate malnourishment. Still, I feel still there is 22% of children under stunting, 5% of children under wasting. We are not happy about our report cards. So we don't feel pride in whatever progress we have made so far, but we are interested in the miles or the goals where we want to go. So next slide, please. So what are the worrisome factors compared to NFHS 4, NFHS 5, the initiation of appropriate complementary feeding has declined by a percentage. That is, by the end of 6th month, the children have to be fed additional complementary nutrition apart from breastfeeding. So in that, we have slipped down from NFHS 4 survey report. So we are planning to address this issue, and we want to encourage the women to give exclusive breastfeeding after 6 months, and after 6 months, immediately to initiate appropriate complementary feeding. So based on the facts and figures, what we have received from the NFHS survey reports, we are working to improve on the indicators where we have slipped down. So for this is next slide, please. For this, the entire integrated child development project, we have 38 districts and 430. This is our setup to address all these problems. We have this infrastructure, and we have 54,499. 54,439 total Anganwadi centers are there. And each Anganwadi center is likely to have a Anganwadi worker and a helper. Next, please. So through these 1 lakh children, we are focusing. We are focusing to, actually the previous speakers have also mentioned, I was attending a couple of sessions. They have mentioned the importance of this first 1,000 days. The previous doctor who spoke the before session also, they were focusing on these 1,000 days. So for this, we have made a video, and that hyperlink is there. I would like to play that video because just people have to watch it. I want to make this video go viral, and we are forwarding so many messages. You can play the video.
Yes, ma'am. 1 minute.
So many messages we are being forwarding. So, and this video can be circulated in social media. Is it coming?
Yes, ma'am. Ma'am, are you able to see my screen now?
Yeah.
Just wait.
Its audio is not coming. Audio is not coming.
Sorry, ma'am.
Audio is not coming.
Just let me check.
Video.
The audio is clear for me, but just
I'm not able to share.
Thousand days.
1000 நாட்கள்.
Yeah.
கர்ப்பமாயிட்டம் தெரிஞ்ச நாள்ல இருந்து குழந்தையோட 2வது வயசு வரையும் 1000 நாட்கள்.
ரொம்ப ரொம்ப முக்கியமான நாட்கள்.
இந்த 1000 நாட்கள் குழந்தையோட மூளை 80% வளரும். இந்த 1000 நாட்கள் அம்மாவுக்கும் குழந்தைக்கும் நல்ல சத்தான உணவு, தடுப்பூசி, குழந்தைக்கு தாய்ப்பால் கொடுத்து கவனிச்சுக்கிட்டா குழந்தை ஊட்டச்சத்து குறைவில்லாம அறிவோடும் அழகோடும் வளரும். பிற்காலத்துல அவங்களோட உழைப்பு திறனும் அதிகமா இருக்கும்.
கர்ப்பமான முதல் 270 நாட்கள் கர்ப்பகால கவனிப்பு. இத குடும்பத்துல இருக்கிறவங்க தான் கர்ப்பமா இருக்கிற பொண்ணுக்கு கொடுக்கணும். சத்தான உணவுல இருந்து மருத்துவ பரிசோதனைகள் மற்றும் தடுப்பூசிகள் மாதிரி எல்லாத்தையும்.
அடுத்த 150 நாட்கள் குழந்தை பிறந்த உடனே குழந்தைக்கு முக்கியமான ஒரே உணவு தாய்ப்பால் மட்டும்தான். அது தவறாம கொடுக்கும். குழந்தையோட EQ, IQ அதாவது உணர்வு திறன் மற்றும் அறிவுத்திறன் மிகவும் அதிகரிக்கும். அதனால குழந்தை பிறந்ததுல இருந்து 6 மாதம் வரையும் குழந்தைக்கு தாய்ப்பால் மட்டுமே கொடுக்கும். குழந்தை பிறந்த உடனே தேன், சர்க்கரை நீர், கழுதைப்பால் கொடுக்கவே கூடாது. மேலும் தடுப்பூசியை தவறாமல் போடுங்க.
புதுசா பிறந்த குழந்தைக்கும் தாய்க்கும் நல்ல சத்தான உணவு, ஓய்வு, தாய்ப்பால் தர சூழல் இது எல்லாத்தையும் ஏற்படுத்தி கொடுக்க வேண்டியது கணவர் மற்றும் குடும்பத்தில் இருக்கிற ஒவ்வொருத்தருடைய கடமை.
7 இருந்து 24 மாதங்கள் அதாவது கடைசி 550 நாட்கள் குழந்தைக்கு தாய்ப்பாலுடன் இணை உணவு, சத்து மாவு, வேக வைத்த மசித்த காய்கறிகள், சூப் போன்றவை கொடுக்க வேண்டும். ஊட்டச்சத்து மிக்க புரதம் நிறைந்த உணவை கொடுங்க. காம்ப்ளிமெண்டரி ஃபுட் அதாவது இணை உணவு கொடுக்க ஆரம்பிங்க. மசித்த பருப்பு, வேக வைத்த மசித்த கிழங்கு, முட்டை போன்றவை கொடுக்க வேண்டும். தாயும் சேயும் நலமா இருந்தா நாடே நலமா இருக்கும்.
குழந்தையும் ஆரோக்கியமாகவும் அறிவாளியாகவும் வளரும்.
இதெல்லாம் உங்க வீட்டு பக்கத்துல இருக்கிற அங்கன்வாடியில தெரிஞ்சுக்கலாம்.
ஒருங்கிணைந்த குழந்தை வளர்ச்சி பணிகள் துறையில சத்து மாவு, முட்டை, தாய் சேய் நல கல்வி இதெல்லாம் தராங்க.
தாய் சேய் நலம் ஒரு குடும்பத்தோட நலம், நாட்டோட பலம்.
Thank you. It was a 3-minute video. Actually, it was prepared by the National Film Development Corporation. And we have made a shorter version of this video also as 30 seconds video. And we are actually telecasting in the news channels also right now. And our request is, hello, I'm in a meeting. I'm doing a presentation for UNICEF. Hello. Is it audible? I'm sorry, I had a call.
Yes, ma'am.
This 30 seconds video we are right now telecasting in media also. Our request is, the department request is to make it more public and so that it reaches to the entire population of the state, country, globally also. Based on this 1000 days, which the importance of which was focused by many of the speakers earlier also, and the department is also focusing on that to ensure that the pregnant women and the lactating mothers follow this. Now we have printed, next slide please. We have printed a calendar exclusive for the mother, and this is a book which is a 30-page booklet we have printed, and this we are giving it to every mother. So which indicates that for the first 6 months that dates will be mentioned, day 1 to 180, in which every day the mother feeds, how many times she feeds the child. She makes a mark of it, whether they have done the breastfeeding on that day sufficiently. And even the breastfeeding practices, how to feed it. You have to feed continuously till the baby sucks one full breast. It is not that changing breasts very often will get the first time they will be getting a diluted milk, and after some time they will get thicker milk. So it is necessary. These feeding practices our workers on just imparting the knowledge on the mother, how to handle the baby, how to breastfeed the child. And it is irrespective of how many times the baby feels hungry, the frequency of feeding, and the time, how many times they feed, everything. These knowledge is being imparted by all of our Anganwadi workers to the pregnant. Each center may have 7 to 10 pregnant women and maybe 5 to 7 lactating women. So this 10 to 12 women who are enrolled in ICDS to avail the services of the program, we give a special focus whether their weights are monitored and they take necessary food in time, and the balanced diet is being taken, and the child feeding practices. And this is a tool, the calendar-like thing which we have printed, and this is given to each mother to monitor herself whether she is feeding the child properly and appropriate nutrition reaches the child. Next one, please. Next slide. So this is the beneficiaries list. No, previous one. So, previous one. No? Previous slide, please.
Has it changed now?
This shows the number of beneficiaries. So the different group of beneficiaries, 6 months to 1 year, who will not come to the center, but they will receive the complementary food. The complementary food alone they will receive, and we actually impart knowledge for the parents, their in-laws, and to commence complementary feeding exactly by the completion of 6 months. And this is one group where they receive only Sattumavu. For children 1 to 2 years, apart from this complementary food, Sattumavu packet, 1 boiled egg per week. So every Wednesday, the mother will come to the baby, just get the egg, feed it. The boiled egg will be given, feed it, and then she can leave. For 2+ children up to 6 years, they attend the ICDS center. They receive complementary food and midday meals program, and that which has a Bengal gram component, green gram component, potatoes on Friday, 3 boiled eggs. For non-egg eating children, providing banana. And this hard-cooked meals is supplied to actually 2 to 6 children who are attending ICDS centers will get hot-cooked meal. Though Government of India is providing midday meals only for children of 3+, state government has taken that initiative to provide meals for 2+ children also. And we have 7 lakh pregnant women and lactating mothers and adolescent girls in the age group of 11 to 14 who are out of school children. Because regular school going children, they will receive their noon meals in the schools itself. So we are focusing on adolescent girls. That's why the number is less. Adolescent girls in 11 to 14 who are out of school. The next slide. Next slide, please. And this is the composition of the weaning food which we give. So, which has millets also, protein content. For sugar, we are avoiding sugar, and for iron, we are adding jaggery, and vitamins and minerals appropriately pre-mixed. And each 100 grams of food, which gives 400 kilocalories of energy. And this was decided by an expert committee, and this food was introduced 3 years back, 2018 it was introduced. Next slide. This is the entitlement each children will get, each child or the pregnant woman. This is their entitlement. Per day, this much ration will be given, and this they can take home and they are supposed to eat. But our field inquiries and studies reveal that I'm getting a chat box questions. Maybe I will answer at the end.
Yes, ma'am.
Yeah. This entitlements is per day entitlement for different categories of beneficiaries, and this they can take home. And our field inquiries reveal that this food is so tasty, and this various types of meals can be made from the single flour. Some kolkatai, urundai, payasam, kanji. So it can be made with salt or sugar. And it also has jaggery, and different preparations can be made. Adai, paniyaram, so many varieties. And the entire sattamavu we give for the child for 15 days, maybe it goes for a single meal for the entire family. So this sometimes disappoints us, because we want to take care of the nutrition of the child or the pregnant women, but it is being shared. Next slide, please. So other health services are also being provided, and VHM regularly visits our Anganwadi centers. And once in 6 months, the RBSK team of doctors also come and visit. And the children are taken care of any serious illness or early identification of disabilities, etc. Especially to address anemia, we have this vitamin A and iron syrup given to the children under 5. Twice a week, 1 ml, Monday and Thursday, even the Anganwadi worker will provide the iron syrup. Next, please. So this is one very important issue we are addressing. The community-based events. We want to create awareness among the community about the importance of nutrition for the pregnant women and children. Now, for this, we want to create awareness about the government schemes, Prime Minister's Matri Vandana Yojana, Janani Suraksha Yojana, so that they can benefit. And apart from the Government of India benefits, the state government adds something more, nutritional kits like this, which has dates, horlicks, ghee, and extra nutritive items the government of Tamil Nadu is providing. So we are creating awareness among the beneficiaries to avail these services and to improve health-seeking behavior, to identify any discomforts in their body and seek medical advice. Next slide, please. So themes for community-based events, maybe you have to go and click. So there are different themes. So how can we? These are the themes for which Annaprasan Divas is just first the complementary meal introduction, Subhoshan Divas, even for adolescent girls who are attaining puberty, just to have a self-awareness, the self-hygiene practices, and whether if the bleeding, the cycle is not regular, if it is something extra. So what is normal and what is abnormal, we have to teach them and create awareness among the adolescent girls. And then we want to do the early registration of pregnant women during the 1st and 2nd trimesters, so that their health conditions can be monitored continuously. All the immunizations are done in time, and their weight is being monitored. And this are every Wednesday, each Anganwadi center will conduct these community-based events on specific concepts, and it will be discussed on that day. Every Wednesday, there will be an event happening in the Anganwadi center. Next slide, please. So this is training the Anganwadi worker. What should the Anganwadi worker tell the public, tell the pregnant woman, tell the lactating mother, tell the in-laws, tell the husbands? So what they should say, this is the incremental learning approach. We want to build the skills on the frontline workers who would like to, who will be the face of the entire project. So we want to build the skills for these frontline workers, and we have developed, the Government of India has funded, and we have developed 21 modules for which the district level master trainer will be trained at the state headquarters, and they in turn will go back to the district and conduct training for all the workers at the block level. So maybe in batches of 25, 30. This district level master trainer will go and train the field workers. Next slide, please. So this incremental learning approach we strongly believe, and we have developed the content in the vernacular language, and we are doing intensive training. Next slide, please. There are 21 topics. See, each one, there are 21 modules in which we have already trained, and refresher courses are also being happening. So first is mapping and enumeration. So survey and the entire area, and an Anganwadi center is supposed to cover say 800 to 1,000 population, and the families and who are living in the entire area will be listed, and who are likely mothers who are expecting pregnancy, newlywed, who is in that reproductive age, who can expect, who are expecting pregnancy. This enumeration is that by itself is an exercise. And then visit every home visits, planning and management, and then execution of community-based events at Anganwadi centers. Then breastfeeding. Breastfeeding is an exclusive module which focuses on the time, how to hold the baby, how long you should feed. If the baby sleeps, what should you? After feeding, what you should do. So all this exclusive breastfeeding itself, it's a module. And in case of underweight babies who are less than 2.5 kgs, on this week newborn care, that is a separate module. And what are the extra care and the mother should take, and how the baby should be watched closely to really actually bring back to the normal weight. And then commencement of complementary feeding at the end of 6 months. And then anemia, consumption of how to address anemia, maternal nutrition pre and post nutritional care, that is another thing. And height weight measurements. What is stunting? What is wasting? The age appropriate height, age appropriate weight. We need to sensitize the parents, especially mothers, whether their child is growing properly. The normal height is there, normal weight is there. The age appropriate WHO charts is being familiarized, and then mothers are imparted with the knowledge of correct weight and height for the age appropriate growth. And then complementary feeding, support to exclusive breastfeeding is about the family support. Educating the mother is one important factor, but educating the family to support. If the girl is working and she's not getting 6 months maternity leave, then what should we do? The baby need to be breastfeeding should not stop at if the lady is going to work in the middle. So the support from the family is also very critical to continue exclusive breastfeeding for the 6 months. So that itself is a module, and this knowledge is being imparted to the family members. Next, please. So there are 21 modules. Each module has a specific content, and this content we are training the Anganwadi worker, and this Anganwadi worker is supposed to tell the appropriate beneficiary. So if it is a lactating mother, what is to be told? If she is a pregnant woman expecting baby, adolescent girl, what should we do? And even the relatives, they ought to be enlightened. The supporting the mother in breastfeeding, feeding during illness of the mother, illness of the child. So what should be done? So there are specific modules this we have developed. Government of India has funded this, and these 21 modules we are training the Anganwadi worker. And every year, a half a day refresher courses is also being done. Next, please. Next slide, please. And that's it. Integrated Child Development Project is is a state level scheme which spends around 2,500 crores every year to reach 7 lakh odd pregnant women and 25 lakh odd children under 5 years. And we are focusing on not only on nutrition, but also growth monitoring and identifying some children severely undernourished. And we are focusing to prepare our Anganwadi workers to address the issues of the 4 types of beneficiaries I have already mentioned: children under 5, under 6 years, adolescent girls, pregnant women, and lactating mothers. And so we continue to work forward to reach our target population. Thank you.
Thank you for the very interesting session, ma'am. We have gained a comprehensive understanding of how the integrated child development scheme of the government is actually caring for the mother and the young infants, and the different efforts that have been put into implementing the scheme. And we just got to know that there are different effective ways, like the video you just showed us, ma'am, and the brochures that have been developed and disseminated to the general public, especially to reach out to the pregnant mothers, and the different modules that also have been developed to young, to train all of those frontline workers, because they are the ones who go directly interact with the pregnant women. So it is very important for them to have basic knowledge about all of those things. So thank you so much, ma'am. It was a very interesting session. Ma'am, there are a few questions in the chat box. Can I please ask you all the things?
Yeah, please.
One is from Dr. Rama, ma'am. Ma'am wants to know the variety of rice that is being offered, and ma'am wants to know if it includes millets, ma'am, such as same and so on.
Right now, it is not there, but actually, discussions are being on. And in our complementary food, the Saktamavu, we have included ragi food. So millet is included in that weaning food, not in the midday meal. Millets is not included in the midday meal, but that weaning Saktamavu has it.
Okay, ma'am. And ma'am wants to know if the 100 grams is for one serving or for one sitting, ma'am.
It's per day. So we are giving per day. So it can be split into any number of servings. So maybe a child can take 10 to 15 grams during. Maybe one small urundai like this will be 20 grams. So that it can be split into, and different meals can be made out of the same flour. It is our calculation is based on the caloric requirement, and we are giving 100 grams per day, and it can be given for many servings.
There's one more question, ma'am, from Dimple. She wants to know that if there's any other replacement for vegetarian children, ma'am, instead of bananas, because banana was mentioned there.
This is the existing scheme. We should, what else can be done? Maybe if she has a suggestion, she can suggest. Maybe we will think it over.
That's so kind of you. Thank you so much, ma'am, for joining us.
Sorry, ma'am, do you have any incentive for the Anganwadi workers, who really perform well? Like some star rating?
Actually, the growth indicators, they are measuring and putting it in the portion tracker. No? So based on the 100% coverage of children in their area, so we provide them an incentive every month based on their performance, how they enter data, and the adequacy of the data, correctness of the data. So incentive is being given to the worker. So
is it the monetary?
It's a cash incentive.
Oh, okay. Thank you, ma'am.
So it means we are motivating them to measure and enter the data in a correct form.
Thank you, ma'am.
Thank you so much, ma'am, for graciously accepting our invitation and for joining us today, ma'am, despite of your busy schedule. Thank you, ma'am.
Thank you.
I cordially invite Dr. Suganti to present the Rapporteur's report.
Good evening. I'm very happy to present the Rapporteur's report today on advances and challenges in maternal and infant nutrition. In his presidential address, Dr. Dinesh Kumar stated that issues to be addressed are maternal age, nutritional and socio-economic factors, among others. The triple burden of malnutrition, that is overweight, underweight, and hidden hunger, that is micronutrient deficiency, can be tackled by micronutrient supplements, lifestyle modifications such as increased physical activity. In the keynote address by Dr. Vijaya, she indicated that anemia, hypertension, and postpartum hemorrhage are few of the common factors for maternal mortality. Interventions right from the planning stage of pregnancy are necessary to ensure maternal health. A state and national certification called the Lakshya program aims at improving the quality of service provided to pregnant women and newborn. Dr. Chitranjan Yajnik stated that there has been a progressive decline in maternal malnutrition, whereas maternal overweight has drastically increased. Micronutrients, especially B-complex vitamins like folate and B12, help prevent gestational diabetes mellitus and also facilitated normal growth of the fetus. Low B12 and higher folate consumption in the mothers was linked with increased adiposity and pre-diabetes in the baby. The implementation of vitamin B12 along with IFA will provide manifold benefits in maternal and infant well-being. Dr. Usha Ramakrishnan, in her talk on trends in maternal nutrition in low and middle income countries, stressed that the role of the first 1,000 days in an infant's life is very critical. She stated that concentrate on the health status with which a woman enters her pregnancy, focus on and also asked us to focus on adolescent girls. She also highlighted the fact that while rates of undernutrition are gradually declining in low and middle income countries, there is a constant rise in obesity rates. In her special address, Dr. Soumya Swaminathan, Chief Scientist WHO, enlightened the audience about the importance of adequate nutrition for the prevention and treatment of diseases among infants and mothers. There was emphasis on the need to practice exclusive breastfeeding and give adequate care to low birth weight infants. She also stressed on the fact that nutritious balanced meals should be given and locally available foods should be included in the diet. And she asked for a holistic and comprehensive approach to be provided to combat malnutrition. Dr. Praveen Kumar, in his session on management of acute malnutrition in first 6 months, explained the increasing risk of malnutrition among the infants, especially in the first 6 months, and also highlighted the various programs and policies available at the community level by the government for the infants and mothers to eradicate malnutrition. Dr. Sharika Yunus stressed on the importance of adequate nutrition in first few years of life. She also brought out the role of grassroots functionaries in education on complementary foods and also provision of fortified foods to combat challenges while complying with WHO quality standards. And Srimati V. Amudavalli, in her speech on conception to toddler, that is government cares, highlighted the objectives and services of ICDS, and she also shared nutritional indicators and showcased an educative video that has been developed with a request to make it viral. Thank you.
Thank you, ma'am. We have had plenty of intriguing sessions for the past 2 days, through which I think we've gained an in-depth insight into the theme of the conference. We have come to the end of this very productive 2-day conference, and I now request Dr. Sharifa to introduce Dr. Avula Lakshmiya, sir.
Good evening.
Valedictory.
I'm very happy to welcome all of you for the valedictory function of the 2-day international conference on advances and challenges in maternal and infant nutrition. It gives me great pleasure to welcome Dr. Lakshmiya, Secretary, Nutrition Society of India. Actually, he has an academic background in medicine and public health with hands-on professional experience in public health nutrition at the ICMR National Institute of Nutrition, Hyderabad. Currently, he is the Director, Grade Scientist, Head, Division of Public Health Nutrition, ICMR National Institute of Nutrition, Hyderabad. He has been working for more than 30 years in the ICMR Hyderabad in various positions, that is from Scientist B to G. He is also National Secretary, Nutrition Society of India. He has carried out more than 50 large epidemiological studies, translational research cum impact evaluations, and randomized clinical trials in the field of nutrition and health. He has also conducted many training and capacity building programs for health and nutrition functionaries of various states. As a lead scientist, he has developed cereal pulse mix, milk-based ready-to-eat take-home ration, supplementary food, Balamurdam, for 6 to 35-month-old children, which is being distributed in Telangana state and Andhra Pradesh daily for about 60 lakhs children. He has published more than 150 papers in national and international peer-reviewed journal, important ones like Lancet, Lance Global Health, Nature, eLife, Obesity Research, British Journal of Nutrition, Public Health Nutrition, Maternal and Child Nutrition, Indian Journal of Medical Research, etc. He has received several awards and honors, to say a few: International Union of Nutritional Sciences Fellowship for International Training and Travel Fellowship Award to attend African Nutrition Epidemiology Conference, Ghana, South Africa, held in the month August 2006. INF USA Fellowship Award for Training Institutional Research Capacity Strengthening in Nutrition in 2007. Kraft International Travel Grant Award to attend 10th Asian Congress of Nutrition in Taiwan. Cambridge University International Health Professional of the Year 2010 by Research and Advisory Board. Postdoctoral Training Award from Bristol University and London School of Hygiene and Tropical Medicine, UK in 2012. He is Honorary Senior Research Fellow in the Faculty of Medicine, Imperial College, London, from January 20 to January 22. He has received many Best Scientific Paper Awards. Sir, it's really, we are very happy to welcome you, sir, to give the valedictory address for our conference, sir. And thank you once again for all the help rendered last 2 years, sir. But for your help, it would not have been possible for us to run the activities of Chennai chapter, sir. Whatever we have achieved, it's mainly because of your guidance and help, sir. Thank you, sir. I welcome you all for the valedictory address, sir.
Thank you very much for Sharifa for your good words, and I'm also very pleased and privileged to talk about this new valedictory address. And it is a very good afternoon, one and all, and thanks to all the speakers, very good speakers, because 2 days it is a continuously. So I was attending almost all lectures, because these lectures are very informative and very even strategic action plans also they have given. And some of the action plans are very successful in their respective states, and because those action plans we can scale up based on these interventions. And as you know, especially I'm just my internet is a problem. I would also like to thank all the organizing committee members, including especially Dr. Sharifa and Dr. Gauri, Dr. Anthony, so Dr. Kamakshi, Dr. Suganti, and their untied efforts and their very a meticulous planning. This conference, international conference, is very successful, and she used to discuss every 2 days, every weekly 2-3 times, because one speaker is not willing to come, what to do, and we have several discussions, and ultimately, so we could organize it very effectively. So this, because I'm also very proud to success this program, because it is a NSI conference. So as being a secretary, so we are also very happy, the family of NSI members. So we want this kind of international interventions, international conferences in every chapter. So we have, as all of you know, we have 36 chapters, but still only half of the chapters are very active, and another half, in spite of our encouragement and in spite of our motivation, so they are not come forward, because nowadays conducting conferences, seminars, and these kind of things is very easy. And we have several opportunities and several topics and several research areas. We could do many things, and yesterday, Dr. even Dinesh Kumar and Dr. Hemalata also sent a message that because the main objective of NSI is the dissemination of new research. Wherever the new research is there, we have to disseminate all the nutrition fraternity throughout the country and even throughout the world also, if possible. So that is the one of the important objective of the NSI. So with that objective, we are moving forward, and some half dozen chapters are very active, and they are because every month they have been conducting several programs, and it is very useful, and so much of this student faculty. So by conducting this kind of programs, the student faculty, the students, especially for even post graduation and research scholars, will get very good benefit out of these programs, because this kind of a detailed teaching will not be happen at in the classrooms, because one topic, it is detailed in a detailed manner in each topic. In the conference mode is the entire information is given these conferences, and the students can utilize in a better way. So as we discussed, the rapporteur also said several things, because she also presented the entire report, because the richness of the program. What I observed is the program is very rich, and the speakers also very renowned speakers, especially Dr. Yagnik, because they are international renowned scientists. Dr. Yagnik, Dr. Dr. Swaminathan, and even Dr. Praveen from Delhi. So and Srimati Amuta, just now she spoke entire about the ICDS program and what are the strategies they are using and what are the problems, gaps. So she nicely revealed all those things, and so definitely this whoever is attending the conference, and they are benefited with the new bundle of knowledge and on maternal and child nutrition. So the maternal and child nutrition is a long-standing and significant public health concern, and contributing to maternal mortality, fetal growth restriction, and neonatal health and child undernutrition. These are the four important problems it contributing. That's why maternal undernutrition is very, very important, and is very critical to take up immediately. Even though,
sir,
hello, is it
not on, sir? Is it purposefully you have switched off, or
is it audible?
The video is not on, sir.
Yeah, video not on because the bandwidth is low.
Okay,
I'm talking from home.
Okay, sir. Thank you, sir.
Okay. Right. And nearly 3.1 million annual child deaths and 35% of disease burden among under 5-year children attributed to neonatal or maternal undernutrition. So the concept, because we are aware that the consequences are very extreme, and especially in developing and developed countries, and especially in like Southeast Asia and India. So the maternal and child undernutrition is a predominant risk factor for about, because recently even Lancet publication, and see even UNICEF reports. So the contribution for contribution for under 5 mortality is very high, because around 2/3 of the cause could be the undernutrition, especially maternal undernutrition. So in half of if you see the pregnant women and the reproductive age, so the low BMI, body mass index, low BMI less than 18.5% is almost 1/3 of the people are suffering, because National Nutrition Monitoring Bureau, we conduct a periodic surveys, diet and nutrition, And even if time trends, if you see the time trends of every 10 years, we used to collect for tribal population, rural population, urban population. So the maternal undernutrition, CED, chronic energy deficiencies, even though it is reducing, but still it is very high level when you compare with global standards or global statistics. And the recent NFHS 5 reports also says that the anemia, the prevalence of anemia, micronutrient deficiency is very high, especially anemia is more than half of these pregnant, lactating, and even NPNL women are suffering from anemia. So in spite of several nutrition intervention programs and the problem is what we have observed in several evaluations, and from NIN we have done several evaluations, even midday meal evaluation, ICDS evaluation, IFA tablet consumption and its impact evaluation. All the evaluations revealing that the quality of the supplies, quality of the product, and not only quality, and coverage itself is very low. So even still, in spite of this lot of technological improvement, and even this time also some of the section of the population even still unaware of these programs, especially this IFA tablet program, even massive dose of vitamin A supplementation for children. So several programs we evaluated, and the ignorance and the lack of knowledge is still 1/3 of the people or mothers are revealed recently. So another important problem is especially even the series of these NFHS studies showing that the undernutrition, especially stunting, wasting, the reduction is not going in targeted targeted reduction because of this high undernutrition, maternal and child undernutrition. Even the Honorable Prime Minister started Poshan Abhiyan. Now Poshan Abhiyan 2 also started. So under that Poshan Abhiyan, because several gaps are identified, and in order to overcome these gaps, Poshan Abhiyan 2 also started. And these the aim of this Poshan Abhiyan also to improve the nutrition status of mother and children, as well as also to improve the life, the human capital, because now everyone is talking about human capital, because we have a young population, but more proportion of young population living in India. So if we utilize this young population and healthy and productive, so definitely India will gain more GDP, and even economic power also will be achieved, and even the present government also to take this India into a 5th or 4th position from economically globally. So if that is to be achieved, means we have to, our youth population also should be productive and nutritionally best thing. And all these problems, whatever the child nutrition problems are, because of the maternal undernutrition. So how to solve this maternal undernutrition? Now we are also focusing, several speakers also said that we have to focus on 1,000 days. If you focus on 1,000 days, then probably we can also achieve this achieve and reduce the undernutrition, and we can improve the health of the mother and children. And especially in India, about 20 or 1/5 of our children are born with low birth weight. So this born with low birth weight is just because of maternal undernutrition. So if you take care of maternal undernutrition, we can reduce the low birth weight. The problem of low birth weight, you are all aware that even low birth weight child is continued. Most of the low birth weight children are continued to be carry over this undernutrition into a school age and adolescent, and even adolescent age. If the girl is an undernourished adolescent girl, even if she marry, she can also produce undernourished child. So that is the intergenerational cycle repeats. So our efforts should be, you have to break this intergenerational cycle to improve the health and nutrition status of mother and children. Ultimately, we will get the very healthy, productive human capital. So that is also most of the even speakers also stressed around this problem. So to also address a maternal undernutrition and critical opportunity gaps. So critical opportunity gaps is identified in several interventional research projects. Even several speakers also said that if once we started any nutrition specific intervention, and the periodic evaluation is very, very important, because without that periodic evaluation, the program cannot be successful. And that is very, very important, because nowadays, if you take our ICDS or MDM, so the implementers, the programmers, they are putting a lot of efforts to implement properly, but there is no proper evaluation process, so that we are missing. So if the proper evaluation process is there every 2 years or every 3 years, and what are the gaps are there still in spite of our good efforts, and those things also we have to bring up, and if you solve the gaps, then it will be then only we will reach whatever the set targets. Whatever the set targets, if you want to reach, we have to do all these issues. So we are spending a lot of money on inputs and the process, but we are unable to put some amount on evaluation and supervision and monitoring of these programs. We are totally failing on monitoring and supervision. Otherwise, if you focus on monitoring and supervision, any programs will not be successful. So that is one important thing. Even other speakers also mentioned, but I am also focusing on this important occasion. And one more area is diet. Suppose we have, you are all aware of that, even NNMB reports are available on the NAN website. In any report, if you see, either it is a rural report or urban report or even tribal report. So the main important positive factor for this high undernutrition is inadequate diet. So the dietary consumption levels are not adequate, even though if cereals are adequate, and other qualitative foods are not adequate. So we are heavily failing to consume the adequate diets, and especially healthy diets. And recently, even CNNS report, you might be seen everyone, CNS report, the Comprehensive National Nutrition Survey, and carried out under the leadership of Ministry of Health, UNICEF, and even NAN also part of the study. And what we observed in the CNNS is the same thing, that the gaps are very high. And so these gaps we need immediately correct. And now we are also talking about undernutrition, but even overnutrition is also an important problem nowadays. And the CNNS report several insights given around cardiometabolic risk factors, and the lipid profile even among children also very high. So this is another side of the problem. It is another side of a coin. So the problem of double malnutrition is also we have seen. So here then we have also the healthy diet. So healthy, we have to encourage to eat a healthy diet, and then if you recommend the healthy diet, even we have to address all food system also, because the counseling is easy and educating to eat a healthy diet is easy, but the problem of availability, affordability, these are the issues also we have to discuss in this occasion. And the problem of availability, and food rates, and even price and other things, how it run in the market. It is demand and supply. Until unless if demand is created for healthy food, the farmers cannot grow the healthy food. Otherwise, whatever the commercial crop, money-oriented crops only the farmers can produce. So these are the issues also we have to solve, and other issues also there in the food system. Lot of storage problems and transport problems, pricing problems, and the farmers, any crop is not may not be much remunerative for farmers. So these are the so many issues around the nutrition improvement programs. We have to solve each issues, and as you are all aware of that, nutrition is not a single department can do. In nutrition issues, we can give several, because that's what it is a multi factorial in nature. That nutrition itself, or undernutrition, if you say, it is a multifactorial and multi-departmental problem. And even in National Nutrition Plan, if you see, and the National Nutrition Plan of Action, if you see, so they have identified almost 13 to 14 departments. All together only should work for improvement of nutrition. Only one DWCD and only one health department cannot improve nutrition status. Because even Poshan Abhiyan also, they have identified at least 6 primary stakeholder departments. One is DWCD as a nodal department, and health department, and not only health, and agriculture, rural development, and education. And these are the WASH program. These are the 6 primary stakeholder departments. Until unless these primary 6 stakeholder departments together work for a common goal, then only we can achieve the good nutrition for mother and children. But the convergence, we are also talking about convergence of all these departments. Since 20 years or 30 years, we are talking about convergence, and 2 departments never meet. So that is also one important challenge for improving the maternal and child nutrition. Because always if health is one side, and if the DWCD one side, if agriculture is another side, rural development is another side. So they are not working together for improvement of nutrition. So the objectives and whatever the set goals is not possible to achieve. So that is also one important challenge, and we have to work together, and we have to, our common goal and motto should be same. So then only we can achieve. And the Poshan Abhiyan says that we have to reduce undernutrition every year 2 percentage points. But in reality, we are not able to reaching even 1% of increase. So we have to put so much efforts to achieve the 2% reduction in stunting, and 3% reduction in anemia. For the next immediate goals are 3 years, and we have to achieve by 2020 to 23. We should achieve these goals. So then everybody should work hard, and everybody should motivated, and this kind of meetings and seminars, and more dissemination, and more counseling, and more motivation of the soldiers, like nutrition functionaries, health functionaries. If you do, then only we can achieve the targeted goals. So then once again, I'm thanks to everyone, and the congratulations for all the organizing team for nicely organizing, and it is I feel that it is a very great successful program. Thank you for giving this opportunity, because you are from the morning to evening, you are tired, and I don't want to take much time, because everything is already said by all the eminent speakers. Thank you.
So
thank you so much, sir.
Well, sir, just 1 minute, sir. Will all the committee members switch on your video? We want to take one screenshot.
Yes.
All the committee members, please switch on your video. So, Anita, Usha is there?
Emma,
Usha? Who else is not there? Anita is there. Anita? Someone send we can take a screenshot. I'll just call. Anita, yesterday also she was not there, mom. I'll just, sir, 1 minute, sir. I'll just send message to both.
Yes.
Ma'am, Anita is here. Usha ma'am is not there.
Menaka is there.
அவ்வளவுதான் அப்ப எடுத்துடலாம். இது இதா இருக்கு, அசிங்கமா இருக்குல்ல. Lakshmi, can you take without the other participants, Lakshmi?
Ma'am, let me try, ma'am. Can I take it using my phone, ma'am?
Yeah. Phone one. Screenshot is better. Print screen. Maybe we just have to cut it, or Usha has to come மேல வரணும்ல. அந்த இடத்துல ரெண்டு ரோல இருந்தா.
No, you can do it after
it's over. No, they won't wait for long.
What about Dr. Suganti? She was there.
Suganti
is not here anymore.
I'm here, ma'am.
Ma'am, I'm not able to take a screenshot, ma'am.
Srinivasa sir, could you help in taking the snap, sir?
I will take in my system also. I have taken one screenshot. I have taken now, Menaka. Thank you all very much. Thank you. Thankfully, now today the program went on smoothly. Yesterday we had few glitches in the beginning, and then thank you all very much. Thank you, sir.
Okay, all the best. Bye.
Thank you, sir.
Thank you, sir. Gratitude is the fairest blossom which springs from the soul, said Henry Ward Beecher. With this quote in mind, I would like to welcome Dr. Gauri to deliver the vote of thanks.
Sorry, Gauri.
Actually, ma'am, you thanked everybody, so it makes my life very easy now. So, anyways, on behalf of the Nutrition Society of India, Chennai chapter, I would like to thank Dr. Hemlata, Dr. Lakshmaya for all the help that they have rendered towards this conference, and Dr. Lakshmaya enthusiastically participated in all our programs, and he was very instrumental in even bringing up, giving us suggestions for the book and also being there for the book release. Thank you, Dr. Lakshmaya. We are very grateful to all our speakers, Dr. Dinesh Kumar for delivering the presidential address, Dr. Vijaya for her keynote address. Both of them stepped in the last minute and very graciously were able to be part of our program. And Dr. Soumya Swaminathan, who despite her very busy schedule, managed to find time for us at an alternate time and day. Thank you so much. And for all the excellent presentations by Dr. Chitranjan Yajnik, Dr. Usha Ramakrishnan, Dr. Praveen Kumar, Dr. Sharika Yunus, Tirumadi Amudavalli for their excellent presentations. I would like to thank the authors of the scientific writing, Dr. Usha Antony and Dr. Annie Kuriachin, for being with us yesterday and for speaking a few words about how useful it would be to the research community. And also Ms. Emmy for designing the book page, and Dr. Ms. Ruth Nayantara Devidar for meticulously designing the contents and bringing it in the form of a book. Thank you so much. I would also like to thank Ms. Dimple, Ms. Emmy for making all the changes in the invitations and the brochures, and every time there would be a change and they would willingly do it and send it to us immediately, and Ms. Hina for designing the poster. And also the research scholars from Ms. Dimple, Emmy, and Ms. Amanda, and research PG students of SRMC, Ms. Noora, Ms. Vanshika, Aishwarya, and Ms. Pratishta for helping us with the Rapporteur's report today. A big thank you. And for all the students and research scholars who participated in the poster competitions and the judges, Dr. Jahanara and Dr. Supriya from SRMC and Dr. Jahanara, retired faculty of JBAS. We are extremely grateful to you for having evaluated the posters. Then to the press and the and Kalina TV who had covered our conference proceedings, and we're very grateful. And to all the students who have logged in today and yesterday, and the faculty, nutritionists, dietitians, thank you so much for being with us on both the days. And I would like to place on record a big thanks to our convener, Dr. Sharifa Talha, who has been meticulously planning each and every day. She would come up with some suggestions or like queries, and taking time to totally plan this event. Dr. Rama, who despite being abroad was gracious enough to be with us at all meetings at odd hours, and also actually sowing the seeds for this conference. Dr. Usha Anthony and all the EC members who have given their entire time for the whole conference, virtual conference of 2 days. Thank you so much. And I think with God's grace, we have actually managed to conduct this program without the initial glitch that we had. So thank you one and all for being with us on these 2 days. Thank you so much.
Thank you, Gauri. Thank you very much for being the organizing secretary. Really have taken half the burden from my shoulder, and of course, with the others. Thank you very much, Gauri.
It was a pleasure working with you, ma'am. So working with everybody, the team was so good.
It was really good. I'm really grateful to all of you. Thank you all once again.
Thank you.
And also a big congratulations to all of you and to the team, especially those who are managing for the 2 days, all the technical side, how strenuous it is, and it must be full of tension. But you carried off with a smile nicely without losing your temper or your patience. And that was very nice to see. Thank you very much.
Thank you, ma'am. Thank you all for joining us once again. The feedback link has been posted in the chat box. We request you to fill it in for you to get your participation certificates. Thank you so much. Looking forward to meeting all of you very soon in another interesting event.
Thank you all.
Bye-bye.